Well, thank you. I get one thing I can guarantee up front is I will not be doing any singing. So this will be a little down to earth compared to some of the other talks, going over current therapies and what we have and what we can do about them. So I have no commercial interests that are in any way conflict with this talk. So I'm going to talk a little bit about, of course, what are our current therapies, what are the successes, what are the unmet needs, what are the failures, and Dr. Goldstein has obviously touched on this quite a bit already. What are the alternatives to what is the generally current standard of care, and a very brief word about opportunities to add to the current standard of care. And I would say that, in summary, it's almost never too late to adjust your immunosuppressive regimen, even if you're on something for many, many years. There may still be opportunities to improve things. So when I was thinking about this talk, actually, I was writing the talk. I was mostly done with the talk, and I realized, well, wait a minute, whose point of view am I talking about here? Realizing I'm talking to a lot of patients. And so from the medical center, as has been mentioned, we are focused on patient survival, graft survival, and obviously saving money. That's what the medical center pushes us all the time to do. Get patients out of the hospital, don't get them readmitted, use the cheapest drugs, whatever it is, don't spend money. From the patient's point of view, obviously living is an important thing. Having your kidney function is an important thing. And nobody wants to spend time in the hospital. It's not exactly the same as saving money. But people don't want to spend time in the hospital. Patients want to have fewer side effects, improve quality of life, pill burden, all the things that have been briefly talked upon that Karen talked about initially. So there's some overlap, but there's not complete overlap. And it's important to keep this in perspective. And I would say up front that my talk is really going to focused more on the medical center point of view on patient survival and graft survival up front. There's very little data in what I'm going to say on patient-reported outcomes. But that's the fact of life, and this is a big unmet need, but I can't invent the data. So we talk about immunosuppressive therapy. I look at it in three ways. There's what we call induction therapy, which is more powerful medicine given only in the first week or so after transplant. There's maintenance medication, which is forever, more or less. And then there's anti-rejection in the unfortunate instance that there is a rejection episode. So we're really going to talk about maintenance immunosuppression, which is what patients are, in our current state of the art, need to take long-term. So there are, a variety of flavors of this. I'll go through this really quickly. Calcineurin inhibitors. There are two, cyclosporin and tacrolimus. Cyclosporin really revolutionized the field some 40 some odd years ago. Tacrolimus has largely supplanted cyclosporin. These prevent immune cells largely from producing growth factors. This is quite a gross oversimplification, but the major thing they do. We have anti-metabolites, largely mycophenolate, which can be given either as an immediate release form as Cellcept, or Myfortic, which is a slow release form. And the drug that really put transplant on the map in the 1960s was azathioprine. These cells prevent immune cells from proliferating. So if there aren't enough cells that are able to cause rejection, then rejection doesn't occur. A newer group of drugs approved in the 1990s were called mTOR inhibitors, sirolimus or everolimus, and they prevent immune cells from responding to growth factors. We have steroids, which have been there since the day one of transplant. They work by multiple mechanisms. I'm not going to go through that. They're anti-inflammatory. They have some effect on lymphocytes. They have an effect on macrophages, all the immune cells that actually make rejection possible. And prednisone is, of course, the one that patients are all familiar with that is given long-term. The new kid on the block is what's called a co-stimulation blocker, belatacept, marketed under the name of Nulogix. And these prevent activation up front of the whole anti-allograft immune response. So what is the current status? And you've seen slides that look like this. All these slides are generated because the federal government mandates the collection of data on transplant patients, which is a wonderful thing. It gives us all this information that we can look at. And so this looks at what drugs are people on at the time of their discharge from the hospital. And so you can see that tacrolimus mycophenolate and steroids is by far like 70% of patients are on that. 30% of patients more or less are steroid-free, actually, by the time they leave the hospital. Now they're on tacrolimus and mycophenolate. And then everybody else, the few remaining percent of patients, less than 10% combined, are on some other regimen as of 2022. And you can see that nothing's really changed in the past many years. These are the regimens that are used. This is what everyone does. What are the results? This was touched upon by Dr. Goldstein. So you look at the 1-year success rate. And for deceased donor transplants, it's 95%, plus or minus. Doesn't matter if you're a man or a woman. If you get a live donor, it's closer to 98%. So these are fantastic results. The long-term results, however, are disappointing, again, as was touched upon. So if you look, different colors represent the survival, the graft failure rates, actually. So going down here is actually a good thing. In other words, the lower the number, the lower the percentage of graft failure. So if you look at the 10-year success rates, you can see that in 2005, the 10-year failure rate was roughly 55%, and now it's down a little bit under 50%. So there's no progress, but it's rather disappointing compared to the 1-year success rates. You can see the 1-year success rates are so good that there's very little room for improvement. There's always going to be some unexpected, unfortunate outcomes early on that we just can't, very impossible to make those disappear completely. But the difference is enormous between the early survival rates and the later survival rates, and progress has been incredibly slow, and the opportunities for progress in the short term are minimal, realistically. Our drugs do a great job early on. Surgical techniques are terrific, and we know how to manage patients in those first year or so. If you look at the living, this is for deceased donors, the living donor story is the same. As was pointed out, its survival is better at any time after transplant if you get a living donor compared to a deceased donor. And so the 10-year graft failure rates are only about 30%, but that's still a lot for getting a live donor and only lasts 10 years. That is a rather substantial disappointment, I'm sure, for anyone, for the donor and the recipient. And obviously, if the graft fails, that can't be an easy thing. A patient goes through quite a bit of trauma, time in the hospital, a lot of drugs, all kinds of side effects by the time that happens. So why does this happen? So the long-term graft failure, about 50% of the patients die, and 50% are still alive, and the kidney has failed, and they're potentially go back to having another transplant or go back to dialysis. Why do people die? They die from cardiovascular disease, infections, and malignancy. Why do people's grafts fail? They fail, 2/3 fail from immunologic reasons, and about 1/3 fail from what we consider to be non-immunologic reasons. Immunologic reasons, obviously, are rejection, and non-immunologic can be drug toxicity, recurrent disease, or just the kidney has been damaged from one reason or another, that the kidney has a maladaptive response in trying to adjust to the fact that there's reduced nephron mass. So in red are all the things that the drugs may play a role in, do play a role in, or don't play a role in. So first of all, they're not as effective as we would like them to do, right? So obviously, if they were more effective, we wouldn't have immunologic graft loss. No one would reject their kidney. There wouldn't be drug toxicity. So that's one thing. They're not as effective, and they're toxic. So they're toxic in direct nephrotoxicity, in particular, calcineurin inhibitors, tacrolimus. They don't help a maladaptive response. They contribute to reduced nephron mass, and that contributes to a maladaptive response in the kidney. They don't have much effect one way or the other on recurrent disease. And they clearly contribute to patient death in terms of cardiovascular disease. Obviously, they're immunosuppressive, so they increase the risk of infection and malignancy. So we have a lot of challenges with our drugs. So I'm going to first talk about calcineurin inhibitors. They're great in the short term. They are the most effective of all the anti-rejection medications. They have really enabled us to, in many ways, to get the 1-year success rates to be as good as they have been. And that has led to, admittedly some complacency in the field. I think that's no longer true, but it was true. And of course, we were all graded on that by the federal government. And, if a patient at any cost had to get through the first year to keep this transplant center alive. But in the long term, these drugs have lots of problems. They're nephrotoxic. They contribute to hypertension. They contribute to lipid disorders. They contribute to hyperglycemia and diabetes to the extent that up to 35% of patients become diabetic at 3 years after kidney transplant who were not diabetic before, not known to be diabetic. They also have neurologic side effects. So the obvious question is, why don't we just stop them, right? Patients a year out, they're doing great. Why don't we just stop the drugs? That seemed like a great idea. Trials were done. The trials failed miserably. Even patients that were selected to consider to be low risk, no rejection, good eplate matching, everything else you can imagine. When they did a trial, it seemed a totally reasonable trial. It was a very important trial to do. Rejection rate was extremely high. So just getting rid of them doesn't seem, at this point, we don't have, that alone is not a great option. If we look at the, when do these things occur in patients? So cardiovascular death is really the biggest cause of death anytime, certainly in the first 6 to 12 months. Pre-existing cardiovascular disease, the stress of surgery, introducing these drugs may play a role. And cardiovascular disease kind of stays along as one of the highest causes of mortality at any point. But cancer is important, and infection-related deaths are also important, and they increase over time. Again, if we had different medications, these might improve the survival of the patients. Again, I apologize, we're not talking about patient-reported outcomes in terms of quality of life. We're just talking about surviving and having a functioning transplant. So what can we do? Well, we can stop the steroids. We know steroids have tons of side effects, potentially increasing the incidence of diabetes, so stopping them can reduce it. They're better for controlling blood pressure, make that easier. They reduce metabolic bone disease. They have, as we heard earlier, they have effect on cosmetic effects and many other effects that aren't listed here. So we can do steroid-free. As I showed on an earlier slide, 30% of patients are off steroids from day one, not day one, but by the time they leave the hospital, usually within the first week after transplant, the first 4 or 5 days, the steroids are stopped. This has been done. We know this can happen, and it can be successful. For patients having side effects of mycophenolate, we could potentially switch formulations. There's Myfortic is a slower release form compared to mycophenolate mofetil, which is originally marketed under the name of Cellcept, which is an immediate or faster release form. Some people tolerate one, not the other. There's always opportunities to switch. One can switch to azathioprine if neither is tolerated, so there are options there. If a patient can't tolerate those, we can stop the tacrolimus or cyclosporin after a year. I talked about that already. That doesn't seem to work. We can substitute a slow-release form of tacrolimus for the immediate release form, and I'll say a word about that. We can substitute sirolimus or everolimus, either for mycophenolate or for the calcineurin inhibitor. That's had very mixed results, in part due to a lot of side effects of sirolimus or everolimus. And finally, which I'll spend more time at the end, and substitute belatacept for tacrolimus. So steroids, I mentioned, 30% have stopped, don't really get any steroids, just a bit at the beginning. And we know this data shows there's an improved cardiovascular risk profile, an equal long-term survival of the graft and the patients. There may be an increased risk of rejection along the way in the first year, but this seems to be minimal, and it's no question that this works. 30% of centers do it, and there's no data shows that that's disadvantageous. Obviously, for selected patients, that may be very important to stay on steroids for one reason or another, but for the vast majority, they can come off steroids. Late steroid withdrawal, if you're already on prednisone, the first 3 to 6 months or longer after transplant, there's not a lot of good data. We don't really know whether it's safe. There's no established protocols for doing this. And so I would be leery if someone's on long-term prednisone of just deciding they're going to get off it. There's a certain kind of common sense that if everything is going well on this regimen, why mess around? But again, it depends on the patient's side effects and how eager people are to do this. But there's really no great data to support that, or exactly how to do it, or how to monitor the patients. Several years ago, a new form of tacrolimus was released. That's called Envarsus, and it's a slow-release form. If you look at this slide, this shows the concentration of tacrolimus in the blood of the patient taking it. With the immediate release form, as you might imagine, the level in the blood rises very rapidly to high levels, then falls off fairly quickly. Again, it's a twice-a-day medicine, the immediate release form, so the level rises again with the second dose. Interestingly, not nearly as high for reasons not well understood, and then gradually declines again until we get back to hour zero when the patient takes the next dose. If you take the slow release form, as expected, the rise is slower, the peak is not as high, and the decline is more gradual, and so the end result is pretty much the same. And the overall exposure, which is how much area is under each of these curves, is pretty much the same. This lack of peak is made up for by the slower decline in the level. So by avoiding this very high peak, there's good evidence that in many patients, this can reduce some of the side effects. So potentially switching from the short-acting to the long-acting form can improve patient experience. So-called brain fog, tremulousness is a very common side effect from tacrolimus. Patients complain of memory loss, and some people have these very unpleasant paresthesias or painful burning sensation in their hands or feet. So this is an option, switching from one formulation to another of tacrolimus. And this seems to be quite safe. There are formulas that calculate what the dose should be, a short period of increased monitoring, and it can easily be done. So what about converting from a calcineurin inhibitor? Seems to be the main villain here. It's both the hero and the villain, unfortunately, in the world of transplantation. So we can convert to either an mTOR inhibitor, which is sirolimus or everolimus, or we could convert to belatacept. So there's not that much to say about conversion from a calcineurin inhibitor and mycophenolate to sirolimus or everolimus. A couple of studies were done. The CONVERT trial, you can see this is 15 years ago, and this is pretty much the same period of time, a little bit, maybe 12 years ago, 13 years ago. The Spare the Nephron trial with the idea that we could substitute a drug that was minimally nephrotoxic, not perfect, for calcineurin inhibitor. They didn't really actually show much benefit. Unfortunately, these were shorter term, these were 2-year studies, and so it is possible that had they gone on for longer, it might have been a benefit. But the difference in the GFR at 2 years was, I think, 61 mLs per minute versus 59 mLs per minute. So it was pretty unimpressive. But the other problem is there was a very high rate of intolerance to sirolimus. 25 to 30% of the patients just had too many side effects and dropped out of the study. So these are difficult drugs to use. For patients who tolerate them, we have a number of patients on them from very early after transplant now for 20 years, doing fantastically. But a lot of people just can't take these drugs. They cause edema. They may cause hyperlipidemia. They can cause some skin lesions, et cetera, et cetera. And the unfortunate thing was the patients who needed a switch the most, who had the worst kidney function, did very poorly. We were part of a trial on this, looking at patients with poor kidney function, trying to get them off their calcineurin inhibitors, who had extensive calcineurin inhibitor nephrotoxicity. They did not do very well switching. It was just too late. So patients, if they're switched, need to be switched early. But there's just not much data to really support this. However, there's some patients, there's really a great benefit. And several studies have been done for patients who have multiple squamous cell cancers of the skin. This is a plague in transplant patients. The rate of squamous cell cancers is 100 to 200 times that of the general population. And so for people who have multiple squamous cells, recurring squamous cell cancers, there's good data showing that switching from either a calcineurin inhibitor to sirolimus or everolimus, or switching from the mycophenolate to sirolimus or everolimus will dramatically reduce the incidence of new squamous cell cancers. This is a 5-year study. There was greater than almost a 2/3 reduction in this rate of new squamous cell cancers. So this can be done either, again, substituting for a calcineurin inhibitor, usually do this with a very, very reduced dose of calcineurin inhibitor, when it's been quite successful. Okay, the new kid on the block, and really the most interesting, I think, dramatic thing is conversion from or never starting a calcineurin inhibitor, or only a brief period of calcineurin inhibitor use, of tacrolimus use, to belatacept or Nulogix. So how does this drug work? So T cells, T lymphocytes, require a variety of different signals to become activated and to mount a rejection response. So belatacept is able to block one of these signals, the so-called co-stimulation signals, one of the most important signals for lymphocytes to get activated. And so it leaves the cells only partially activated. And for reasons not that well understood, once they're partially activated against a certain antigen, such as an HLA antigen on the surface of your transplant, they seem to never be able to get activated against that antigen again, or very difficult to do that. So that's how they work. They leave the cells sort of half woken up, and they go back to sleep again, essentially. So this is a monoclonal antibody. It's humanized, so there are very few reactions against it. It's given intravenously, essentially once every 28 days, although people have experimented with giving it over a more extended period of times. It's given IV, so patient has to get to an infusion center every month, or have insurance that will allow it to be done at home. The infusions are extremely safe. The number of reactions are minimal, where someone gets sick from actually receiving the infusion. And it can be used either as conversion, or it can be started de novo at day 1 after transplant as a substitute, or in addition to the immunosuppressive regimen. So a number of studies looked at long-term outcomes. I'm going to go through some of those. The initial studies, for a lot of reasons I'm not going to go into, compared belatacept to cyclosporin. Patients got Simulect or basiliximab induction. They were all on steroids. It was a 3-year trial. It was extended through 7 years. If you looked at the overall end results, at 7 years, 12.5% of the patients either had died or lost their grafts on belatacept, and the rate was practically double for those patients who were maintained on cyclosporin. In addition to that, the rate of formation of antibodies against the donor kidney was markedly reduced to about 1/4 of the rate. And this is a major risk factor for chronic rejection and graft loss in the long term. So the end results were excellent. Not only that, but the kidney function off the calcineurin inhibitor was better. And you can see that the curves are a little bit different at the start, but they get better and better. Again, these were patients never on a calcineurin inhibitor. So of course, we expect their results at the start to be better. The curves really start to separate around 2 years. We start to see a difference. There start to be a decline in those maintained on cyclosporin, whereas the GFR actually continued to kind of improve over time, remarkably over a 7-year period. In addition, the overall patient survival, independent of the graft, was somewhat better, significantly better on belatacept compared to cyclosporin. So seems like a no-brainer. The one fly in the ointment, which is very interesting from the immunologic point of view, is that the number of acute rejection episodes in the short term was 2 to 3 times that on the belatacept. There were 2 different regimens. It's not worth going into that here, but the cyclosporin acute rejection rate was only 7%, and it was double that or 3 times that on the belatacept. Fascinating that all those rejections, in fact, did not cause worse long-term outcomes, but in fact, better long-term outcomes and reduced donor-specific antibodies. I wish we understood that better. The donor-specific antibody production is listed here. The 2 belatacept regimens is between 1% and 3%, and 11.5% on the cyclosporin. This is the 2-year data, but the difference was maintained at 7 years. So clearly, this is de novo use, clearly a major benefit. I would say that the group at Emory, and I neglected to put a slide in, has shown that if you continue the patients on the tacrolimus for most of the first year, most of these early rejections are avoided. And so the patients can actually, it looks like you can get, have your cake and eat it too, more or less. You can avoid these early rejections and still get all the long-term benefits by staying on tacrolimus for somewhere between 6 and 12 months. So one of the issues with this was that all these trials used basiliximab induction and cyclosporin maintenance. But now most centers, 70% of people who get induction therapy get thymoglobulin, and almost everyone's on tacrolimus. So does this apply? So we all know that no one's going to repeat the initial studies. They cost hundreds of millions of dollars. The data is there on cyclosporin. No one wants to repeat the whole initial study and go and do it all again and see what happens. And so the next best thing is to try and use fancy statistics to look at how can we best estimate what would happen if we use tacrolimus. And so a study was done and published this year looking at so-called propensity methods to get what happens to patients on tacrolimus today and what happens to patients on belatacept today, and how can we compare them even if it's not really a randomized trial. And so it turns out that the data are in fact the same, pretty much. This is a 5-year study, but you can see that if you take patients who would have been in the study, would have qualified for the study, et cetera, each arm of the study, you can still see that you have a 10% improved survival at 4.5 years estimated using belatacept versus the tacrolimus. And the tacrolimus and cyclosporin arms come out pretty much identical. So it seems like the studies are not going to be repeated, but the data seem to still indicate that there's no question of benefit. And this is for, again, de novo use of upfront use of belatacept. So if it's so good up front, what about people who are already on other drugs? Maybe we should just switch everybody over. So trials have been done in stable patients. This was a multinational trial. Somewhere between 6 months and 5 years after transplant, getting a calcineurin inhibitor, 90% were on tacrolimus and mycophenolate. They were randomized to either stay on their drug or switch. And the calcineurin inhibitor was tapered off completely by day 30. And they were followed. It's a 2-year study. So it was a short-term study. Remember that the difference in GFR, a lot of the benefits were not that apparent in the first 2 years in the initial studies. So what happened? Well, if you look at the over the 2 years, a little over 2 years of the study, there's not really a significant difference in graft loss. It starts to be a benefit. You can see a little bit of a benefit here. Separation in the red is the people on the belatacept. In the blue is the people on the calcineurin inhibitor over 810 days. And so you can see that it's really essentially 2 years. The difference is not significant, but starts to perhaps look like there might be a difference. There are more rejections. We've seen that before at the time of switch. I think some might argue that discontinuing the tacrolimus in only 30 days may have been too quick. Most of these rejections happen during that quite early on, but there are more rejections. So there's no way to avoid that. One of the interesting things about the rejections was there was no antibody-mediated rejection in those groups, whereas over the course of those 2 years, the rejections in the calcineurin inhibitor group, half of them or a third of them were antibody-mediated rejections. So, that's a lot better to have if you're going to have a rejection, not to have an antibody-mediated rejection. But it's clearly when you come off the calcineurin inhibitor in a month, there's a risk of having a problem. What about the GFR? Well, as was shown before, and this is only a 2-year study, but the GFR got better and better in those patients who got off of the randomized to stop their tacrolimus or cyclosporin compared to staying on it, where the GFR slowly deteriorated, and people on the belatacept, the GFR slowly improved. So mimicking what happens. So there is an opportunity to switch in patients. What What about donor-specific antibodies? Once again, belatacept, very few people had donor-specific antibodies at 24 months after transplant. It's 1/7 the number of people maintained on the tacrolimus. So you get better GFR, you get less chance of having donor-specific antibody. And so, for many patients, this may be a good option. Certainly for anyone having lots of problems with the tacrolimus, it certainly seems like a good option. So that was just randomizing people who were willing to be randomized. They were not specifically people having problems, although you might say that those people willing to be randomized, maybe they had a sense that this was not so great. I want to have the opportunity to get off something, but that was not part of the trial. If you look at people who are so-called defined as having calcineurin inhibitor intolerance, and you do the same study, again, you get, and these are long-term patients, you get similar results. You get better survival of the allograft on the belatacept, again, in red, compared to the calcineurin inhibitor maintenance group. De novo antibodies, again, these are people having some sort of problem, was half as much in the belatacept compared to the calcineurin inhibitors. And if you look at people who already had donor-specific antibodies, those who are switched, the graft survival is significantly better than those who stay on the calcineurin inhibitor. So even those people who are in trouble seem to benefit. So that's it for the switching of drugs. I just want to say one very quick word about additional agents that may benefit patients. They're not immunosuppressants, but patients who have diabetes, and perhaps all transplant patients, we don't know. And these are the things that we all have heard about constantly in the newspapers these days. The GLP-1 receptor agonists, Ozempic or Trulicity, the whole group, though, that family of drugs, and the SGLT2 inhibitors. These are drugs introduced for the treatment of diabetes. And when the studies were done, it turns out that actually they have great cardiovascular benefit, and they also have kidney preservation benefits. And so the data that's so published to date is very limited, but these are being used more and more in transplant patients. There's no question in diabetics that they preserve kidney function and they reduce cardiovascular risks. These are non-transplanted patients. There's no reason to believe the data won't be the same in patients with kidney or potentially other organ transplants. So the preliminary data is very promising, and use is, I think, growing quite rapidly, but we need to hear more about this. So in conclusion, I think immunosuppression does not need to be one size fits all. The most promising progress is the belatacept, either de novo or conversion. Despite the fact that there's a short-term risk of rejection, the long-term benefits have been reproduced in multiple trials. Conversion to sirolimus or everolimus is of limited, if any, benefit. It is possible that longer term, maybe there is a benefit. The studies were only 2 years. The high rate of side effects is a problem, but obviously for people who have having major problems with squamous cell cancers, this may benefit. And if you saw that article on the front page of the Times, I think within the past couple of weeks, if you take sirolimus, you might live forever. So it's, I don't think I believe that, but this is out there. It's actually been out there since the day sirolimus was approved. This was rats live longer and et cetera. In fact, the person who discovered the drug developed cancer and took sirolimus and thought that he actually did better that he would have done otherwise, not taking sirolimus. Of course, it was an N of 1, and so nothing was proven, but this is not a new concept, but it comes back and around, and maybe it'll actually mean something, but it's not a simple drug to take. I repeat what I said at the beginning, and particularly for this audience, one large gap is, as Karen said, and is critical. We don't have patient-reported outcomes in these. We desperately need to get that. I think belatacept clearly promises that should be the case, but we don't know. People have to get stuck in the arm once a month, which is an inconvenience if you're an active, traveling, busy life. It's not so simple, but it's certainly maybe worth it. And of course, the best immunosuppression of all will be none. which is to say tolerance, where we somehow finagle a way to trick your immune system into not rejecting the kidney at all and get rid of all the immunosuppressive drugs. I think Dr. Newell is going to talk about this in the short term, and this has generally involved getting a kidney and bone marrow from the same donor with very intense immunosuppression pre-transplant, the so-called conditioning regimen. So thank you very much for your time and attention.